good afternoon. Good afternoon and good evening, everyone. So I would like to welcome you all on behalf of the International Institute for Primary Healthcare in Ethiopia for this second webinar series, which revolves around strengthening primary healthcare systems in low and middle income countries. And the objectives of this webinar is to create an experience and knowledge sharing opportunity, creating an opportunity for benchmarking best practices around primary healthcare, as well as identifying research gaps in PHC. This webinar series is hosted by the International Institute for Primary Healthcare in Ethiopia in collaboration with the Johns Hopkins Bloomberg School of Public Health. So this webinar is a monthly webinar series, which we launched in January 2022. And it's going to run over the course of 2022 and is loosely organized around the World Health Organization Primary Healthcare Operational Levers Framework. This new series conducted one session a month back, and it focused around primary healthcare workforce. And during this discussion, it really laid a foundation for our current topic, which is gendered primary healthcare. And there were a lot of perspectives and questions raised during that discussion. Without further ado, I would like to go ahead and hand over the session to Dr. Mike Ashlife. Unfortunately, the moderator who was supposed to moderate this session, Dr. Rajani Vaid, couldn't join us today because of overlapping commitments, and Dr. Mike Ashlife as well as Asha George will be taking over the moderation. Dr. Mike Ashlife is the principal investigator for the grant that the Institute is currently working on. She's also affiliated with the International Health Department at the Johns Hopkins University. She specializes in community health and primary healthcare with the focus on improving human resource capacity. And I know she's very passionate about digital learning and the Institute. So over to you, Micah.
Thank you so much, Dr. Frehiwot, and it's really exciting and a pleasure to be part of this session and to collaborate with the Institute, and also to be able to convene experts on these various topics from around the world and be able to think together about where we are with primary healthcare from these different lenses. And the discussion portions of these webinars have really been phenomenal in terms of wonderful questions from the participants and really insightful perspectives from all of the speakers. So it's my pleasure to introduce our three experts today, starting with Dr. Asha George, who will be, as Dr. Frehiwot said, stepping in and also facilitating the discussion in the second part of this webinar. So Dr. Asha George joined the School of Public Health at the University of the Western Cape in 2016. She's the South African Research Chair in Health Systems, Complexity and Change. She's also an adjunct professor at the Johns Hopkins School of Public Health and is a principal visiting fellow at the United Nations University's International Institute of Global Health. She's a qualitative researcher engaged with health systems to advance health and social justice in low and middle income countries, and brings a gender and rights lens where she focuses on the frontline interface and governance of services, taking into consideration community and health worker perspectives. Since 2002, she's co-edited 2 edited volumes, 4 journal supplements, and over 120 journal publications, as well as multiple technical reports and guidance documents. So we're so happy to have you joining us, Asha, and looking forward to hearing from you later in the session as well. Our second speaker is Dr. Rosemary Morgan. She is an associate scientist at the Johns Hopkins Bloomberg School of Public Health in the Department of International Health. Dr. Morgan specializes in the role of gender, power relations in health and health systems, experiences, and outcomes. She is the Gender Equality and Social Inclusion Coordinator for Learning, Action, and Building for Rehabilitation in Health Systems Consortium, the RELAB HS. And she's also the advisor for the UK Partnerships for Health Systems program and the co-primary investigator for a project on risk and resilience in the health workforce, understanding and supporting the experiences of women health workers during COVID-19. She also previously led the Research in Gender and Ethics, or RINGS, Building Stronger Health Systems, which is a project which brought together 4 research networks, including 17 organizations across 25 countries, in a partnership that was really aiming to galvanize gender and ethics analysis in health systems research. So welcome to you, Dr. Morgan, and looking forward to your presentation and discussion as well. And finally, we have Dr. Ficker Asemnuf, who is a doctor from Ethiopia. She's a pediatrician who also has a master's in public health and a number of years of experience, both working clinically as well as in public health practice at the national and international levels. Currently, she's working with the WHO Ethiopia office as a program management officer on gender equity and human rights focal point. She has extensive experience. I want to share a few of her important contributions in Ethiopia and beyond. She's the founder of the Child Abuse and Neglect Unit in Yekatit in hospital in 2001, and a multi-medical disciplinary approach that was really working to protect children against gender-based violence. And she's also contributed to capacity building in a number of different ways, including aiming to narrow the gap between justice in the health sector and bring that in line with medical evidence and sharing of that evidence. She's also contributed to a range of documents for the Federal Ministry of Health as both a writer and designer, including the 2013 First Gender Mainstreaming Manual, and revision of that manual just last year. She's also worked on the guideline for prevention and response of harassment in the workplace, and including a training manual and a strategic plan for 2020 to 2025 for women, children, and youth and gender-based violence for the Ministry of Health. She's also served at the regional states of Ethiopia, across the Somali region, the Afar region, Tigray, Amhara, Gambela, Harari, Deridawa, and more to enhance gender streaming of gender into the primary healthcare system. So we're so glad to have you, Dr. Ficker, to bring that experience from multiple levels working within Ethiopia and beyond as well, and looking forward to your presentation. So we'll hear more from each of the speakers. I'd like to hand over first to Dr. Rosemary Morgan, who will get us started. We'll go through all 3 of the presentations and then have a chance for discussion. So please feel free to put your questions into the Q&A as we go along, and then we'll come to them after the presentation. So over to you, Rosemary, and welcome.
Great, thank you very much. And I'm absolutely delighted to be here today and to be here with all of you across the world to talk about gender and primary health care systems. So I'm going to focus today on looking at gender responsive primary health care, thinking about what that is and what are some key considerations in regard to gender and primary health care that we should be thinking about when we're implementing primary health care. So first, what is primary health care? So it is the most basic package of essential services and products needed to prevent disease, promote health, and manage illness. So really it is about bringing sort of health promotion to the community, to people where they are. And you know, it has some essential elements, which you can see here on the screen. It is quite broad in approach, focusing on health education, thinking about adequate food supply and nutrition, safe water and sanitation, maternal and child health, including family planning, immunization against major infectious diseases, other things like treatment and common diseases and injuries, provision of essential drugs, as well as community participation. But, you know, as we know, when we are implementing things, particularly within the health system and other areas, if we don't think about inequities and how they manifest and how they might affect access to services or use of services, the very people that we're intending to reach with those services are often those that don't benefit from them or benefit much later on, or we might lead to unintended consequences. And today I really want to speak about gender inequities and the role of gender within primary healthcare. And when I mean gender, what I say is, gender power relations, how therefore gender as a social construct, that how it manifests to as an equitable access to resources and as an equitable norms and values about differential roles, distribution of labor, as well as differential decision-making power and autonomy, and how does gender intersect with primary healthcare, therefore to affect access to and utilization of primary healthcare as well as its delivery. So what I want to focus on today are sort of 4 key areas, particularly, thinking about operationalization of primary healthcare from a gender perspective. And these 4 areas are somewhat problematic from a gender perspective, in the sense that, these are, when we're thinking about the standard operation of primary healthcare worldwide, these are some of the things or consistencies that we are seeing which are problematic. So one of which is often a lack of consideration of heterogeneity of communities and patients, leading to a one-size-fits-all approach. The other is often equating women's health with maternal health only. The over-reliance on women's care to distribute primary health care, as well as lack of consideration for issues faced by women health providers. And I'm going to go into each one of these in turn. So let's focus first on the lack of consideration of the heterogeneity of communities and patients, leading to a one-size-fits-all approach. So what I mean by this is, that when we're delivering primary healthcare, we really need to consider the differential health needs of women, men, girls, boys, and gender minorities, and that they're not going to have the same health needs due to both biological but also different gender differences. And the fact that we need an intersectional approach, so that we can't treat all women, men, girls, boys, and gender minorities the same, because they're going to have different needs based on their differing identities. An example might be women with disabilities. For example, if a woman has a physical disability, she may need a ramp to access health services or other forms of care. This also, so this really includes considering how gender and other forms of discrimination affects health status, like discrimination based on race, so racism, for example. Community participation is a big part of primary health care, and we have to think about that, who's included in community participation, whose needs are being prioritized, and who's excluded. So thinking about power differentials and community participation become really important. So moving on to women's health, often equaling maternal health. What we see in many essential packages in primary health care is women's health being reduced to maternal and child health or reproductive health. And sometimes where the focus is mainly on the child, and the woman is seen as a vehicle for child health. However, it's really important that we take a life course approach when we're thinking about primary health care and essential packages, essential needs. We need to think about women, men, and gender minorities across the life course in childhood, adolescence, younger, reproductive years, but also elderly people as well. And then often we're seeing primary health care programs emphasizing women's role as wives and mothers. And by that, that links to, equating women's health equaling maternal health. So if we're only thinking about, health needs of women with a maternal health lens, what we're doing is essentializing their role as primarily wives and mothers, and not thinking about them within their entire, their entire space and lives. So moving on to over-reliance on women's healthcare. Many of us know and probably have heard the statistic many times, that women make up 70 to 75% of health workers worldwide. They deliver care to around 5 billion people, contributing 3 trillion annually, half in the form of unpaid care. So, we really do need to think about women's roles as providers within the health system, and at home as well. A lot of primary healthcare systems rely on community health workers to promote their packages and interventions. And in many contexts, healthcare workers are primarily women, many of whom are volunteers, are very low paid. And the focus on primary healthcare and health promotion and prevention, while very important, through education, when we're promoting education and good practices, the responsibility of that education often falls primarily on women within the home and the community. So women teaching, or their children, or others in the community through community health workers. So the burden that this places on women is something that needs to be considered. So the fourth point was a lack of consideration for issues faced by women health providers, including some of these issues include pay equity, not only in relation to community health workers, but women in the, as nurses, doctors, other healthcare providers, is that often we do see a differential in pay between women and men health providers. Thinking about flexible work arrangements, women do often have dual care responsibilities, working in the home and at work, and have to look after children. And we often see a lack of flexible work arrangements to account for this. Lack of women's representation within leadership. We said about 75% of women occupy health provider positions, but we only see about 25% of women in leadership positions, and that is a concern, because just having women in leadership positions does not necessarily mean that different gender issues are going to be addressed. However, it is an issue, because it's really important that we have diversity in leadership, so we have diversity in voices. And then the protection against sexual harassment and violence is a big one as well. A lot of our healthcare workers in the community and within health, hospitals and other health centers, primary healthcare centers, are experiencing sexual harassment and violence. It's something I think that is a big gap in our research, but it's imperative that we protect women healthcare workers against sexual harassment and violence, and have policies and structures in place to do so. There are other important gender considerations. I'm not going to go into these in huge detail, but I wanted to include them. And of course, they're not exhaustive. So gender barriers to accessing and utilizing care are very important. So how women and girls and men and boys are able to access care, and what might prevent them to do so. Thinking about provision of culturally appropriate care, thinking about disrespectful and abusive care when individuals do access care, and if that's prevalent, and that how some services which are important for women may not be deemed essential depending on the context. This could include access to different family planning for adolescents, or abortion-related care, for example. So what we need is a gender responsive health system. And a gender responsive health system is one in which takes in consideration the intersectional needs of women, men, and gender minorities in the development, delivery, and management of health systems across all health systems, areas, and levels. And this very much includes primary health care. So there's a major need for people-centered, gender-responsive approach within healthcare. Primary healthcare, which means, meeting the diverse needs of individuals, not equating women to only wives and mothers, recognizing and addressing the burden these programs place on women within the home and a community, ensuring meaningful community participation, recognizing role and effect of power differentials, ensuring safe, decent, and equitable working conditions for all health providers, including adequate and diverse representation within decision-making, addressing gender barriers to access to and use of primary healthcare programs, and providing culturally appropriate and respectful care. And with that, I will say thank you and hand it over to our next speaker.
Thank you very much, Rosemary. Wonderful presentation and looking forward to discussing in a bit. So over to you, Dr. Ficker.
Can you see my screen?
Yes.
Okay. So, hello everybody. So I'll be dealing with the gender mainstreaming in the primary healthcare in Ethiopia. Already the major components have been cited by previous speaker, Rosemary, and I will share the experience of mainstreaming would be brief, and it will consist of the introduction of mainstreaming and tools, the tools for mainstreaming gender in the program, and success for the health sector at federal and primary health care, and we'll be dealing with challenges and way forward. So gender mainstreaming, as probably you may know, is a kind of process that will see the implication of women and men in the planned action. It also includes, the mainstreaming of gender in policies, programming, and so on, eventually to come up with equality of men and women. And the objective is to minimize gender inequalities in the health regarding the gender roles, regulations between men and women that varies in society, from society to society. So gender mainstreaming has three components. There is going to be a gender analysis, gender audit, and gender budgeting. And looking at the processes in Ethiopia, following 1985 World Conference of Equality, and also the 1995 Beijing Declaration, and the United Nations, the 15th session that passed resolution to mainstream gender in all policies and also programs, then Ethiopia has taken a big step, a major step to introduce the mainstreaming of gender. And initially it was in 2000, but the 2000 gender mainstreaming manual or guideline was more vertically designed. And later on, through time, the health sector developmental plan 5 particularly emphasized on gender equality. Thus, the gender mainstreaming manual has to be revised in 2013. And this manual has focused on the health system. And later on, again, this has been so many changes has happened in the world. And so the sustainable developmental development goals, and at the same time also the HSTP2 with the gender with the health sector transformation plan. It focuses on equity, and so gender mainstreaming and women empowerment is also being included in this strategic plan for the health sector. And so we have to revise the gender mainstreaming manual in March 2021. And this manual of the health sector is adapted in the mission of the Ministry of Health, and also in the health sector strategic plan, which has around 4 pillars. And it looks into, I mean, in all the perspective, it has included or integrated gender into all the different programs or pillars that are being there. And again, there is a health sector strategic plan that has been developed for women, child, and youth with disability. And it's not only at the level of the Ministry of Health, but also at the different agencies that are, that are under the Ministry of Health. Agencies like the Ethiopian Pharmaceutical and Supply Agencies, Ethiopia for the community-based health insurance, and so on. They all have integrated gender mainstreaming in their strategic plan, in their work. So their work also, streamed down to the health facilities or to the primary health care. So in programming, to bring gender into the different programs in health, there were so many tools that have been used, and one of the tools is the planning. To do gender analysis. There were different questionnaires and gender responsive assessment scale that have been used, and health equity analysis, human rights-based approach, innovate, barriers analysis, and all these were adapted and included so that each program or each delivery of services from the health sector includes gender. And the gender-based violence or sexual violence training package is also inclusive. National prevention response to workplace harassment has been developed, and the health sector is the first, sector or ministry that has developed, the gender-based, the workplace harassment guideline, the prevention and response, including the training package. And at the same time, also it has included the prevention of sexual exploitation and abuse. The other thing is we have a practical handbook for the health worker to translate the CEDAW, the international conventions, into the public health approach of the health response to gender-based violence. And so the success stories is the development of the normatives already being addressed, the capacity building, orientation for the gender mainstreaming. And the orientation is not only to the health workers or the health workforce in general, but also orientation has been given on the importance and how to deal with it to the leadership, higher level, including the ministers and the state ministers and so on. Unless they buy in the issue of gender to mainstream in all the programs and operation, things cannot be moved. And there is an accountability framework, and they have, it has a buy-in. So gender mainstreaming are also being given in different areas or in different health sector program areas. Training on workplace harassment, which is also, as I said, inclusive, is already ongoing. And now it's become mandatory that each of the health workers working in the health sector have to be certified on the workplace harassment that is inclusive also of prevention of sexual exploitation and abuse. And the other thing for the mainstreaming is the advocacy, like gender and emergency, which is already being done. You know that Ethiopia is now currently in some political instability, and also there are volatile areas for armed conflict and so on. So we need the gender to be mainstreamed in all these emergency packages that are being given to the public or to the affected area. It also includes pandemic like the COVID-19 outbreaks. Banning of medicalization of FGM in the health sector, which was also done, and the follow-up is being done. The other thing in operation or studies assessment, gender audit and also gender analysis. some, rapid assessments on gender-based violence response at the national level, and also health equity analysis, which the equity is also inclusive of gender, has been undertaken, and there were so many, studies in line with that. So just to give some example for the mainstreaming of gender. Health information system captures data, in sex disaggregated, which is the start point of gender mainstreaming to do the gender analysis. And also these are very fundamental. And recently we have included disability in the gender-based violence and sexual violence registry. So we are going to have more and more, data disaggregation. Operational mechanism at the federal level was that there was a platform for knowledge dissemination in all the regional states and also agencies for women, and also youth forum. And National Gender Health Forum, established in 2019, is also facilitated the gender transformation approach in the health institution. Coming to the success on the primary health care, capacity building for human capital are also being made, are also conducted, and orientation on the updates of gender to the regional health bureau, the warada or district managers and health workers. Gender mainstreaming training has also been given to the managers and also the workers, and JBV training has also been done. This includes also the gender-based violence training, includes the health extension workers, and these are the lowest unit that addresses the community extension programs, and they were provided how the gender-based violence or sexual violence, how to handle and make a reference, and addressing the community on this subject. Prevention and response of workplace harassment is also underway. As I said, it's also going to be mandatory for all health workforce. It's not selective for health workers, but all health workforce working in the health sectors, they are mandated to understand and know and being skilled enough to act on the prevention and response. Service delivery coverage, I could give you only the 7 months, the recent data. More than 819 health centers in primary hospital. They provide multidisciplinary health response. And also they have registered, these primary health facilities, Ethiopia has more than 3,000 facilities. But these facilities, we are under scale up, but these facilities are connection problem, are providing these services for gender-based violence survivors. 74 hospitals have one-stop center, full-fledged, where the multi-sectors response are being delivered, and which covers around 74% of the target. Up to now, 2,834 female and 104 services, full centers out of the 74, because I could not get the data from the others. Platform established in all regional health bureaus and also health agencies, and youth forum in all the primary health care. And so coming to the what are the factors that for good achievement or for success stories are the government commitment and existence of structures of Women, Child and Youth Directorate. And currently they are called Women and Social Affairs Directorate, global and regional continental agreements, and the presence of global tools, working in partnership with developing partners, and also, of course, the commitment of the health workers are the factors that drive us for success in Ethiopia. Key challenge, well, of course, there are always challenges. Limited experts on gender mainstreaming approach. I mean, to analyze and, the programs and also operation, whether they have included gender in their daily work. Scarce resources, lack of clear indicators for gender mainstreaming, weak multi-program collaboration platform within the Ministry of Health itself and external with different sectors, low attention for analogous structure at regional state, and political instability and conflicts that restrict movement to some regional states. So moving forward, strengthening the mainstreaming of gender in all programs and operation, that's most important. And the ministry is going to, to work on this. Build the human capital for strategic approach of gender mainstreaming, enhance variety of resource mobilization, and also reinforcing the health sector for gender-based violence or sexual violence, including multi-sectoral responses, and strengthening the strategic information, monitoring, measurement, and evaluation are part of the way forward. And thank you, Amasaganal. Over to you, Meg.
Thank you so much, Dr. Ficker, for a wonderful presentation and for really illustrating, some of the extensive work that's happening in Ethiopia, and looking forward to discussing shortly. So thank you, and over to you, Dr. Asha George.
Hi, everyone. I am going to share my screen. Okay. No matter how many times you're on Zoom, it just takes a while to get set up. I'm honored to be speaking with you, and I'm delighted to follow both Dr. Morgan, who gave an excellent overview of gender and primary healthcare, as well as Dr. Tigris Milese, I hope I'm pronouncing your name correctly, who gave such a detailed overview of how do you operationalize this at country level. All the different manuals, mechanisms, the considerations of health workers, the different health conditions. I think it's been an inspiring presentation that gives you a sense of all the hard work that goes into trying to mainstream such a perspective across primary healthcare, which is a cross-cutting endeavor. I'm presenting briefly on some preliminary work that I'm doing. I'm based at the School of Public Health at the University of the Western Cape, and I am part of the Gender and Health Hub, which is a collaboration that is seeking to support gender sort of evidence translation into the UN system, but also back at regional level. So we'll be taking forward some work regionally, meaning the African region, where I'm based, on gender and health. And this is some initial work undertaken with UNICEF on this topic. So I'm presenting some work done with Mamatena Motupi, who's at Kemri right now. She was a postdoc at SOPH, and she is based in Kenya. So just trying to get. This is why Rosemary said she will present her own slides, but I said sometimes my own computer seems to be, here we go. So why does it matter? So as you've heard from Rosemary, primary healthcare, I don't need to tell all of you, it's a strategic foundation that really strengthens health systems. The Alma Ata agenda stretches back in time, but is very relevant today to the contemporary discussions we're having around universal health coverage and sustainable development goals. So while primary health care is part of this trajectory of health systems reforms that are really aiming to address health equity, and it aims to be universal, the specifics of how gender discrimination happens, how gender biases creep in, and how those power relations remain invisible still affect how primary healthcare is operationalized, as Dr. Morgan mentioned. And for me, they sort of affect three broad buckets that are a very key part of primary healthcare. It is there in the social determinants of health, but sometimes remains invisible. It's absolutely a critical variable in terms of health promotion, whether young boys, men, older men, women, whether they're married or not, how do these individuals seek care? And are they able to look after themselves? And then what happens with care provision once they get to healthcare services? As the previous two presenters said, who ends up delivering care and with what quality? And these are all core elements of a primary healthcare approach. Before I go into the framework and unpacking that, I had a few slides on gender. We jumped into this and Dr. Morgan gave an excellent definition. And I know this is very text heavy, but I just thought in case these slides are saved and used as a point of reference, here are two definitions for those of you who may not be as familiar. So gender is, as Dr. Morgan said, is about how we understand the behavior and ability and power that young girls, boys, men and women and gender diverse people have in how they carry out their daily lives, what kind of resources they have, what are they able to take forward in everyday decision-making, and how they're able to look after themselves. It's about how power and resources are distributed in society. And gender is something that's universal, but it means something, those inequalities are pervasive, but they mean something different in every context. And I think it's important to keep that in mind. And that's why I like this image here of what it means to be a man, a woman, or those who ascribe to different gender identities is different in all over the world. We need to pay attention to those contextual differences, but also understand there are some systematic disadvantages. And this is from a figure of violence against women in Europe. And if you look at the statistics of disadvantage, it is still in many statistics where women are the most marginalized. When you look at, they're at the receiving end of the discrimination. So while we keep in mind that there's quite a lot of fluctuation and change, and what gender meant in my generation is very different from my grandmother's generation and means something different in my son's generation. But there are some, so we need to keep in mind how things change, but also pay attention to systematic inequalities that still might be there. Another advance in how we think about gender is intersectionality. And Dr. Morgan mentioned this in her presentation. I think the key thing is this understanding that as human beings, gender is one aspect of how we interact. And so I put this image here. It's a key variable that defines our life course, our everyday decision-making and our life trajectory. But it's linked to class, race, religion, and how those things combine vary. And sometimes you have advantages in one area and disadvantages in another. We need to be mindful of how these inequalities come together and act. If we are to change them, they're not inevitable. We can do something to change them, and that's what we have to keep in mind. So that's my reference slide to sort of situate this work on gender. We took away and tried to think of 5 principles, therefore, What does it mean for bringing into primary healthcare? And the two presenters already outlined some of this, but at a basic level, there's still a push to disaggregate sex by sex. It's striking how many health information systems collect this information, but not necessarily report it upwards and analyze them. And we want to be able to track that because we want to disrupt inequality. We want to have change for the better. And that means looking at these differences, but also looking at how norms creep in and make things seem benign or natural when actually we should be outraged at the inequalities that we see. Dr. Morgan already mentioned this, and the previous speaker, Dr. Melese, showed us the context of Ethiopia. It's important not to assume these things are universal, but to really look at our frameworks and adapt them to different contexts. And at the basis is understanding that these are socio-political inequalities based on power differences. They're man-made inequalities, therefore we can change them. And we need to look at how they combine with race, class, different forms of structural disadvantage. So we looked, and I'm sorry this isn't a very clear image. Many of you might be familiar with this, and there is a forthcoming, that I think in the next few days, they're releasing the monitoring indicators for this framework. And there's been a UN group that's been working on this. So this is the operational framework for primary healthcare that the UN system has been working on. And it talks about the overall approach, certain key levers, and the kind of results they want to see. And I think what's critical for me, what I liked about it is it is a useful framework. It begins to, you saw the very detailed presentation by Dr. Melese, all the different things we must be doing and we can do to bring in a gender perspective, as did Dr. Morgan. And what I liked is that this gives one roadmap. There are many kinds of frameworks, but one roadmap for what we should be doing. And the end goal is to improve access and quality, but also to empower people to look at improved health literacy, participation as a goal in itself, and to address the determinants of health. And that's a little bit linked to these two key points. So while Dr. Morgan mentioned community participation, even this framework, we tend to focus on the health services. And Dr. Morgan focused on the essential package. What is the essential package for primary healthcare? But the spirit of Alma Ata was more than just a tiered system of essential services, but also a system that takes you past those essential services. And if you have a complication, how do you get specialized care? It was talking about a broader system of care or model of care. And a key part of it was where are the people and how are their rights respected? And these two aspects, how are communities and people empowered through the primary healthcare approach, and the importance and contribution of other sectors is often forgotten. And even when I look at this framework, I'm going to focus here on the PHC levers. Many of these levers are about health services, but primary healthcare is much broader. An important point of departure is the health services, but it's more than health services, because in the end, health services are really often, yes, there are preventive and health promotive aspects, but they're about looking after sick people, and primary healthcare is about broader well-being as well, and therefore other sectors are important. So just a few preliminary, I'm going to whiz through this because I think it was covered much more eloquently by the previous speakers, but my point is if we go back to this, I'm going to go through these levers. At every step, there's an opportunity to bring in gender. So if you look at what the UN is proposing as the core strategic levers, political commitment and leadership. As Dr. Morgan said, it's really important to have women leaders, but also what's the broader social contract? Are the women who are put in leadership able to take gender equality affirming decisions, or are they part of conservative parties or neoliberal parties that take decisions to cut health budgets. We need to look at that. And a lot of the governance and policy frameworks were covered by Dr. Melese, the mechanisms of operationalizing our commitments. What are the current review mechanisms? Are there parliamentary committees? There's an important parliamentary committee that oversees the Asha program in India. How has that been an oversight mechanism? Is gender equality mentioned as a goal? Are specific activities mentioned and the indicators? Are we measuring in our policy frameworks what we want to do with gender? What kind of budgets are there allocated to the activities and goals? And are we able to disaggregate funding in the health accounts for and conceptualize what gender budgets look like in this area? And as Dr. Morgan said, community participation is important, but is it whose voices are heard? It's critical that communities are consulted, but we know there are power dynamics within communities as well. So to be mindful of that. Okay, let me keep going and finish off because I think there are over 100 of you on this call and we'd love to hear from your insights. So just a few thoughts on models of care. Sorry, when you talk about models of care, the issue of task sharing comes into place and how are responsibilities, training, and opportunity shared across the health workforce, which is highly gendered. Issues of, there's now a lot of work of mainstreaming attention to gender-based violence. And Dr. Melese touched upon the different specific gender health conditions that make a huge impact on gender equality and how do we bring that into our models of care. Dr. Morgan covered this already. The health workforce, women in global health have been very effective in delivering this message of healthcare services are delivered by women and led by men. And there are many frameworks. This is an article that I pulled together on looking at the determinants of violence against female health workers and using a gender analysis. So there are very structured ways of looking at the inequalities and the gender inequalities in the health workforce. Physical infrastructure, I know one of the first things when you're visiting health facilities, not one of the first things, but always a lingering concern is how functional is just the building? Is there space for the waiting room for families who are also visiting patients? Are the toilets functioning? And there could be a long checklist of things to look for. Medicines and other health products. What are the key drugs? Are they in the essential kits? What is left out? And really a thing with COVID-19 and Women in Global Health recently had a big policy event on this is PPE. Is protective equipment there for community health workers? And across the board, we know many community health workers have been left out. The surgeons have the PPE, but not the community health workers necessarily. And even beyond access, there's the question of, is it designed for women? Women health workers who menstruate, how do they operate with PPE that's not designed for them, especially given COVID-19? The last three elements of the operational levers, engagement with the private sector. A lot of our frameworks for primary healthcare look at public sector, and the public sector is incredibly important as a foundation. But across the world in many health systems, we have mixed health systems, often with a completely unregulated private sector. So we also need to really look at what are the gender considerations there. And what is critical is that for young people, sometimes the private sector and for young men is an important point of contact for healthcare services that they want to have privacy around, that they feel they can't have in the public sector. So we do have a mandate to look at the quality and how they handle, are they gender responsive? And there's a huge push to make things more accessible, and therefore it might be with pharmacists, or in many of our countries, medical shops. They're not formal pharmacists, but you will get access to contraceptives and testing for different things there. So what are the gender dynamics there? Purchasing and payment systems. There's a excellent work being done to point out how a lot of women are in the informal sector. So they are not covered by many of our health insurance schemes. They have less discretionary access to money, and therefore healthcare systems based on financing that is not, if they're not government financed and free on the point of care, they can be further marginalizing. And the last thing was digital technologies. It holds a lot of hope, but it can also have inequalities and it can backfire as well. So we need to monitor who has access, how, and with what consequences. The last three operational levers are all about improving care and using research and evidence. And I think the key things to keep in mind is that we have developed standards that bring in gender responsiveness. One is the whole area of respectful maternity care. These are just illustrative examples. In each country, there will be different initiatives. I think the key thing about research is, does it empower learning from the bottom up? And when there's a lot of initiatives that look at social participation, community accountability, and the involvement of communities in monitoring whether drugs are available and a whole, what's the quality of services is key. But I think we often forget the health workers in those primary healthcare services. Are they themselves, are they just reporting data up to other people? How much discretion do they have to improve and use data to improve health?
Asha, we seem to have lost your audio. Sorry, it was perfect and it just disappeared. Nothing so far.
Yes.
There we go.
Okay, I took my headphones out. So I'm just wrapping up. If we want to bring in gender perspectives, we also need to look at how do we integrate them in conventional research designs, but also how do we look, if we want to bring in lived experience, we need to go to other types of research designs and be more innovative in bringing in people's voices. So my last slide, I've been going on for far too long. I think my last slide was essentially, there are many opportunities for bringing gender and primary healthcare together. As Dr. Melese really showed, there are lots of opportunities. There are very few documented examples at large scale, which is why I think the presentation by Dr. Melese is so valuable. And I think the more we can document the lessons learned, the challenges faced, the more we'll advance, so that we can go from this conceptual framework work to the actual nitty-gritty of how do we do it in government programs around the world. Let me end there, even though I can't change my slides. And I think we're going to open up for discussion. So let me stop sharing. And I'd encourage you to add, we have half an hour, more or less, for discussion. I can see there are some questions. And what I'd love is for, I haven't had a chance to look at the questions, maybe some of them can also be looked at by the participants and answered online. And we have a whole bunch of questions, I think comments in the chat as well. So maybe we should have thought about it. The last presenter can't be the moderator because they're not paying attention to the chat. I see people have their hands up as well. Should we go first with the people with the hands up? And then I'll go to the Q&A.
Micah?
Yeah, so thank you, Asha. Wonderful presentation. And what we were thinking, we were recognizing this handoff as well. And so there have been several questions, both in the chat and in the Q&A, that kind of revolve around the last point that that you made, Asha, around, there are these frameworks and guidelines and, strategies and things on paper, but the translation into practice is complex and challenging. And, as we saw from Dr. Ficker's presentation, there's a lot of really important work going on at multiple levels, and from all of your work as well. So we were thinking we might just open up with that broader question for some reflections around, how we continue to support this translation of the resources and tools that are available into practice, and then hand over to you and take it from there. So if that works for you, we could start there, and maybe hear from Dr. Ficker and from Rosemary, and then back to you, and then feel free to take it wherever it's at that point.
Great. So Dr. Ficker, any reflections listening to both our presentations and your own work in terms of integrating this at scale in Ethiopia? Moving from theory to practice.
Yes, it's not easy. I could not say that it is very easy. The first thing that we need to do, the first thing then foremost is to have an advocacy, the importance or the value added for gender to be mainstreamed into programs and also operation, institutionalization. And this is one of the foremost things that we need to do. And this have taken us time in case of Ethiopia. There was some document, as I said, in the year 2000, but it's not translated into practice. That is one thing. So the other, what we have done is the advocacy, particularly to gain the commitment of government and also of leaders wherever we are working, in any ministry that we are working. This is one thing. Once we have that buy-in, it is the translation into the operational documents, like, the tools, like having gender mainstreaming manuals that directs everyone what to do and how to do it, including in the integration in the system, the health components, the components of the health system, in financing, human resource, quality service delivery, information, and so on. So these are, something that we need to do, to translate it into a guideline, a normative, or a governance document. This is the second thing that we do. The third thing is to capacitate personnel, health workers, because they are the ones who are in between for the program to be realized. The interface between the health worker and the client or whoever is requesting our service, the interface is what we call it the program. Whatever we have, we are going to translate it or to provide services. So this is very important. So we need to capacitate our health workers, including also the health workforce. Apart from that is the monitoring, particularly obtaining information. In order to do that also, there are so many packages of activities that we have to do. It's not, we have to defend and which one are very relevant. There are also so many numbers of indicators within the health system that we have to address. And it could be also cumbersome for the health workers. So we need to be very selective and prioritize what we wanted to do. And so if we advocate also for it to be included in the information system, the health information system, or the DHIS2 and whatever, we are having, like any country can have different forms of capturing data. So if we have that, and also including the accountability for that. So people, tend to see or to report on the values. And the other thing is also, once we have the data, is the planning, or replanning whatever we have. So to plan, we need to have also analysis, a kind of operational research. And we have to use different tools. As I said, we had opportunities of adopting or contextualizing the international or global tools to Ethiopian context, like the different, WHO tools that we have contextualized, and also other tools that we have used. So these are some of the areas, of doing. It really requires energy, and it really requires a talent to pursue the situation. Once we believe and we are committed, this is what we have to do. And finally, as I said, the opportunity, the health workers at different levels, they have to be committed, and they have to be, be part of this exercise because it concerns them. So these are some of the different steps that we have taken, and these are really practical, and we have seen the different, impact on not only the facility readiness, but also the coverage of victims that we are having. So it doesn't mean that we are perfect, but we are doing something and going towards the gender equality. And moreover, I only mention what we have at the health sector level. At the health sector level, which includes also agencies, pharmaceuticals and so on, what you have presented, Dr. Asha. We have, it is also being, mainstreamed in all those agencies, like the Ethiopian Pharmaceutical Agency, what are the different medicine or even supplies or even utensils that we are using. It also includes not only women, but having the disaggregation between men and female, but also people with disabilities. A child may have like a cleft lip and may not even have the materials. If we just categorize, the medicine to be taken for all children, taking children are all the same, that cannot be, address the specific need of that child who had cleft lip. So we need to have an appropriate appliances for medicine and so on when we are, procuring appliance or medical supplies, like suspension versus tablet and so on and so forth, for children and adults and women and who are hepatitis or no. All these have been included, and they are monitoring that also. So even including the community-based insurance, whether gender-based violence or any other related items are free or have been, the people have been insured on that and so on and so forth. So just to say that there are different steps that we need to do, but most important is the commitment of the health worker and having a good structure, well structured, that will even coordinate the different, programs for equity and also gender and so on and so forth. These are very important, and this is being realized due to the commitment of government, starting from the parliament and going down to the ministry level. And so many ministries are also including, as I said, gender into their programming, like WASH. They have started now mainstreaming it, and they have started to develop a steering committee. There are things going on, but I was specific on the ministerial, the health sector only. Thank you. Over to you.
Thank you, Dr. Melissa, for that very comprehensive response. Shows your own leadership, thinking very pragmatically on how to take this forward. Any thoughts from you, Dr. Morgan, in terms of, I think the question was, how do we operationalize these theoretical frameworks and to put them into practice in large-scale programs? And one question from a participant is, do all these different documents help? How do we navigate a way forward? Any thoughts from you?
Yeah, I think it's a great question and very important, because we do have a lot of documents, don't we? There's a lot of tools around gender mainstreaming, and and it's a first step, I think, in understanding how we do it. But as Dr. Melissa said, advocacy, gaining buy-in and support is so important. So we can have these tools and documents to do it, but if we don't have the support, of leadership, of decision makers, both at sort of a more macro, higher level, but within our programs, it's unlikely that we're going to be able to mainstream, to be able to integrate mainstream and gender perspective. And, you know, there are sort of different tricks that one can do for mainstreaming. I think some of us are in organizations and areas that are very supportive of this work. Others are in organizations that are less supportive of this work. And there might be more work on the ground that's needed to be able to do that. And it is overwhelming and confusing. I'm just looking at Nilofar's comment, you know, of where do we start? What can we use? And, you know, when I was preparing for this presentation, I was looking for information specifically around gender and primary health care. You know, we have information on gender and health systems. I saw less specifically. I struggled to find anything really specific on gender and primary health care beyond a couple studies or, you know, toolkits. And I was really, you know, delighted to see, Dr. George, the work that you are doing with the Gender and Health Hub, and hope that that kind of turns into more of a sort of programmatic approach that people can use to really, you know, there was some really solid recommendations in your presentation about the different pillars. And I think you're absolutely right that the one area, you know, there's a question in the chat about what is primary healthcare. And I actually think that's a good question, because when it's so broad, I too was looking at the definition, and I'm like, how does one do a presentation on this topic, this huge, diverse topic, and does it include everything? What is it that we actually mean? And you're very right that often the attention is on the essential health services and very much less on multi-sectoral action and community participation, community engagement and support, and that how, you know, we often first go to the health system, but we really need, it's not just about the health system, it's about other actors if we really want to promote prevention, promotion of health. Because primary healthcare at its essence is about prevention as opposed to cure, right? Let's address the social sustainable development goals, or the social determinants of health, the root causes of ill health, so people don't get sick in the first place.
Thank you. I don't know if there are a few more questions that are very specific about gender budgeting and indicators for Dr. Melese, but before, and thank you for explaining, you know, how do we navigate these documents and the importance of applying it to your context, Rosemary, and that we have a lot of work to do in this area, that there are lots of different frameworks, but adapting them to primary healthcare is not a simple task, because it is a comprehensive perspective. Before I hand over to Dr. Melese to answer about gender budgeting and indicators, is there anyone else who wants, from the participants floor, who would like to share their perspective of operationalizing this in a large-scale government program? I know we have a lot of colleagues from Ethiopia, but we also have colleagues from other countries. So while you're collecting your thoughts, because it shouldn't just be the panelists who are talking, you have a lot of experience yourselves. So while you're thinking about what you want to add, and I'm looking for a hand up, that's maybe I hand over to Dr. Melese to talk about, there's a specific question about gender budgeting and your experience with gender indicators for primary healthcare.
Okay, gender budgeting as one of the components of gender mainstreaming has not been undertaken in at least in the health sector at federal level, and even I haven't seen any document on that with other, you know, federal agencies in health, and so the experience is limited. But I know that it is part of the strategic plan for 2022. So we'll share that if anybody is willing. But otherwise, gender audits have been done at national level under the Ministry of Health, involving all the sectors, and also at the Ethiopian Pharmaceutical Agency level, that have, around 19 hubs at subnational level, and they have included all that. It was also done at Alert Hospital, which is a federal hospital, at hospital level. The audit has been done. It also, provides where we are in the gender mainstreaming and what else that we are going to do, and with different recommendations, which will inform the planning, the next phase of planning. But as far as gender budgeting, I mean, the analysis, I'm talking of the analysis, but not the allocation of the budget. On the analysis, so far, it's not done, but it is planned, and WHO will also support that technically. Thank you. Over to you, if I have answered.
Thank you very much. I don't know, Rosemary, if you wanted to add anything in your experience about gender budgeting per se as a stream of work.
It's not an area I've done a lot of work on, for example, but I do think it's something that's really important, because we know that if we don't allocate resources to this work, if we don't have indicators that are attached to money, sorry, I've got two cats fighting behind me, and you might hear it, but it's very distracting. If we don't allocate resources to this work, if we don't have indicators that may be matched to those resources, there's a chance that it might not happen. It's often one of the first things to go. That's what I find, unless we include this sort of gender budgeting and indicators that match it.
Thank you. I'm just looking, there's
sorry, may I come in, Dr. Asha?
Yes, go ahead.
I said, gender budgeting, the gender budgeting for the activities are there. It's not so much, but the analysis has to be done whether the allocated budgets and the plan that is being done are commensurate, they match together, so that we can advance the gender mainstreaming. That's what I'm saying. As a report, as an analysis, is not done, but the allocation, budgeting, defending, and so on and so forth are done, depending on the country's resources. They allocate some budget, and working in partnership, as I said, is one of the success factors. So mobilizing, leveraging resources from other partners is an important area, but systematic, descriptive analysis for gender budgeting for the country, and so that we can use for advocacy for more allocation of budget on this line. It's not yet done, but it is planned, I know. Thank you.
Thank you. It is an area of specialization in of itself. And I know South Africa, it has a lot of experience in this area. And recently in early February, we had a national policy dialogue on it. There are some countries that have taken the methodology much further than others. I see that we have, and on the question on indicators, I'm going to Google it while others speak. I know there was, I think it was the Health Policy Project in the US that had developed indicators for gender responsive healthcare services, or at the facility level. And I'll see if I can look it up to share. I see a hand up. I don't know if we have just a few minutes. We have 10 minutes left, but if you have a quick question, I wonder if you'd like to speak. There's, I see, Zakari Osheku. Are we able to unmute the person?
Yeah, he has a talking permission, so he can talk.
Great, please go ahead.
Hello, good afternoon. Hello, can you hear me?
Yes, please go ahead.
Okay, first of all, Zachary Osheku is my name. The Executive Director of PHC Initiative Africa here in Nigeria. First of all, thank you very much for the wonderful presentation. And considering the fact that the issue being discussed here is the issue of gender, which is of much concern to the global world as we speak today. So what I want to say is this. There is no doubt that most of the healthcare workers globally happen to be women, particularly the nurses happen to be women in Nigeria. So, and in sometimes the attitude of these health workers towards their fellow women, it's highly uncalled for, which has to give room for, for some of the patients to even prefer dealing with male colleagues. So this is a gap that we have identified. And in as much as we have identified that gap, we try as much as possible.
Thank you. Thank you very much. And it is a finding. There's a Rachel Jukes, I think 15 years ago, had a very good article about nurses in South Africa and how they replicate a lot of the abuse they have faced in their own lives on women who are coming in to deliver in healthcare services. So there are many factors that explain why women health workers can sometimes replicate and provide bad services. It's also where they're located. I'm not excusing outrageous behavior or inexcusable behavior, but they are often at the bottom end of a system that doesn't support them to deliver care, and they have life experiences of abuse. They're human beings, and it's our challenge to bring a gender analysis that puts that into perspective and looks at ways of changing that. So linking to that, there's a question on, I'm going to pass it back maybe to Rosemary and Dr. Molese to close, bring their closing thoughts. And this question from Franco Gabala on how do we ensure voices of marginalized groups get to these high-level dialogue platforms. And so maybe Twinning, if you have any thoughts on this question and any closing comments. Thank you.
Should I go first? Well,
yes, go ahead.
Thanks. Yeah, I think that is a really important question. And one of the principles of primary healthcare is, community engagement and ensuring that the health problems and issues that are being addressed are emerging from the community. But as Dr. George and Melissa both sort of talked about, is that that's an area that is often missed. And yes, we need support and buy-in to be able to do that type of work, but it is about the methodologies, and there are different methodologies that we can use, and ensuring that community engagement is an essential part of our programming, I think is a first step. How there's different ways to go about doing it, but to include them from the beginning, not just a tokenistic endeavor, to have them be part of the process and have structures and systems in place to ensure that we have levers, that connect community and voices to the higher decision-making levels. And there are tools and more and more tools, always tools, but other things to help us do that. But I think it's a principle that first and foremost that we need to ensure that is embedded into the work that we're doing.
Thank you, Dr. Morgan. And thank you also for adding those resources in the chat. I see there's also something from a colleague from JPIGO on transformative leadership that perhaps speaks to what our colleague from Nigeria mentioned. Dr. Molese, any last closing thoughts and reflections on any outstanding questions from participants?
Yeah, I think how do we bring the marginalized group into the higher form of platform is not an easy task to do. But as an agenda, it is entertained with the community through the health extension program. One of the area is on the package of their delivery package, service delivery package, is the maternal or reproductive health in general. So one of the area is the violence, gender-based violence and so on. So I think they have a hearsay on that because there are different platforms that they exist. But to include, in general, as I said, the community are not left behind, and also those who are disabled also are not left behind. We have included even in our registry, I have already mentioned that. And apart from that, there is a link in the primary health care, which are, in our setting, the primary health care constitute the primary hospital and the health centers and also the health extension program. These are the three areas. So these are convened by the Warada, and the Warada are included in the platform for Women Forum, Youth Forum, and so on, and to capacitate their knowledge and also as well as their skill. So there are always forums to bring the challenges and also to resolve the challenges, jointly in a participatory approach. So what I want to say at last is always we need to start, we need to have commitment. And once we are committed, I think once we are changed also, we can change the others. And it has to come from the inner self. This is what I want to say. Everyone who has been attending this forum, I think they have to be committed and work towards the equality goal. Thank you. Over to you.
Thank you so much, Dr. Melissa. A lovely way to end, because really striving for gender equality in primary healthcare, health systems is a lifelong endeavor. So you have to have passion linked to that commitment. And I think what you spoke from your own experience really resonated with others, and also the resources and insights shared by Dr. Morgan. One reflection I have on this question is colleagues in India have done a lot of work bringing community voices. Just like in Ethiopia, we have very strong community health programs. We have a lot of activist NGOs that are involved in social audits, decades of social mobilization. So it takes time. It takes time to win the trust of communities and bringing them to these forums. And the other key thing, I think, is we need to train the health decision makers when they come to this forum. I know when I was part of one meeting in India where, as civil society actors, we were so happy that colleagues from the Ministry of Health came to the table. And then, because we had spent a year working with civil society actors, doing tracking on health services, and we were bringing these experiences of what needed to change with government services. And then what ensued was a long lecture from the health policymakers on all the things they were doing, and there was very little time left for dialogue. So it is a training that has to go both ways, and it is quite difficult. It's easy. There are a lot of programs. You need time for community, for those at the community level, but we also need time and dialogue to engage with our health decision makers, because sometimes they are also not always in a listening mode. And I think that's the message from me. For us to improve, we all need to listen and learn to take this agenda forward. I want to thank everyone who made the time to come, to share their experiences. I know not everyone got a chance to ask, but we look forward to staying in touch to realize this very important element of primary healthcare. Thank you very much. Let me pass it back to Dr. Fairwood and Dr. Mike.
Thank you, Dr. Asha, for wonderful moderation and all the presenters for a wonderful presentation. It was a very interactive session, and thank you for the participants for being here and for staying with us throughout. If you're interested in knowing more about the Institute, please visit our website, and also please continue engaging in our upcoming webinar series. We have this every month, so we look forward to seeing everyone in the next session, which will be happening at the end of March. So thank you, everyone. Micah, do you have any last words?
Nothing other than also to add my thanks, and excited to continue to hear from those who've joined the session. And thank you so much to all of the presenters. Have a wonderful rest of the day.
Thank you, and bye, everybody.
Bye-bye.
Bye.
Bye.